Welcome, everyone, to our seventh and final community workshop of CHIPS Equitable Injectable PrEP in LA County Initiative. Title of today's presentation is Expanding PrEP Use in Los Angeles County 2024 and Beyond. I'm Ron Brooks from the UCLA Department of Family Medicine, and I will be facilitating, today's workshop. Next slide. So our workshop, here's the agenda for today's workshop. I'll quickly review workshop logistics, provide an introduction to the LAI PrEP project initiative, and introduce our featured panel discussion. That will be followed by a 20-minute facilitated question and answer period, an evaluation, and closing remarks. We have reserved time at the end of the workshop for you to provide an evaluation of the workshop and some other closing remarks. We will conclude the workshop with a raffle for 3 $50 gift cards. So I urge everyone to stick around because this may be your lucky day. Next slide. Workshop logistics. So if you need it, select the closed caption option on your Zoom control panel to enable closed captions. We will be using this chat function on your Zoom panel control to share your questions for our panel or comments or resources for the group. During the Q&A portion of the discussion, use the raise hand function, please, so that we can call on you to address your question. As a default, participants will be muted and videos will be disabled during the workshop. If you have any technical issues, you can contact Enrique Sanchez in the chat function. Next slide. So the Equitable Injectable PrEP initiative is supported by an EHC supplement grant from the National Institute of Mental Health awarded to the UCLA Center for HIV Prevention, HIV Identification, Prevention, and Treatment Services, otherwise commonly known as CHIPS. The UCLA CHIPS team includes myself, Ronald Brooks, Dr. Delara Uscoop, Omar Nieto, and Elena Rosenberg-Carlson. This project is a collaboration between UCLA CHIPS and the Los Angeles County Department of Public Health's Division of HIV and STD Programs. Our community partners, supporters include Friends Community Center, Bienestat Human Services, In the Meantime, and the LA County Commission on HIV. So some background for this initiative. So historically, what has happened is that Black and Latino men who have sex with men and Black and Latino transgender women have lagged behind more privileged and more well-resourced white gay male populations in receiving information about the latest innovations in both HIV treatment and prevention. Unfortunately, as a result of this, these populations have not benefited from early adoption of highly effective HIV innovations. This has contributed to the disparity in HIV that persists today in these vulnerable populations. So the initiative seeks to address this delay in disseminating information on the latest HIV innovations. In this case, it's the most recent innovation, which is injectable PrEP, to our priority populations of Black and Latino, Latina, transgender women, and men who have sex with men in Los Angeles County. To do this, we have been implementing a series of online community workshops to provide accurate and up-to-date information on injectable PrEP-related topics and other PrEP-related topics that are of relevance to our priority populations, both consumers and their service providers. I'm happy to introduce our exceptional panel of speakers for today's workshop, beginning with Dr. Sonali Kulkarni, who's the Medical Director for the Division of HIV and STD Programs, commonly known as DHSP, for the Los Angeles County Department of Public Health. Richard Salazar is the EHE Prevent Pillar Lead at DHSP, and also Dr. Siri Chiru Mamiya, who is the Associate Medical Director at DHSP. So I will now turn over the workshop to our presenters, starting with Dr. Sonali Kulkarni.
Great. Thank you so much. Richard, if you could bring up the slides and screen share, that would be wonderful. Thank you, Dr. Brooks, and to the UCLA CHIPS committee. It's been great to be part of your collaborative here to really help engage the community around long-acting injectables. Um, and so, yes, we are pulling up the slides as we speak. So, and we will be sharing the slides afterwards as well. So, that was a question I saw in the chat. We're seeing your slides in more of a like your internal view, so you can lower that.
I'll just add a comment that if people have questions during the presentation, we're going to have a specific question and answer period, but you can put those questions into the chat so that we have them available at the end of the presentation for the Q&A session. Thanks.
So Richard, we need to start at the beginning of the presentation. If we could go to the front. Okay, great. Thank you. All right. So I think we already did our introductions, but thanks again. And it's great to see such great turnout for the presentation today. I think it really highlights the continued interest in trying to expand PrEP use in our community. So next slide, please. All right, so today what we're going to be covering, myself and my two colleagues, is sort of the current state of PrEP use nationally and in Los Angeles County, talk about new approaches that we have been working with, as well as our clinical partners on expanding PrEP use, and then share some LA County PrEP resources that may be of use to you and your partners. Next slide. So I have two polls to start out with. So Omar, if we could launch this first poll. So the question is, since 2013, approximately how many people in the United States have ever received a PrEP prescription? So the options are 500,000, about a million, about 2 million, or 5 million people. So let's see what folks think. Give everybody a minute or two. So Omar, can we close the poll and see, or are you just waiting for more responses? Okay, so the results are about the majority of people think it's 500,000, 30%, a million, 27%, 2 million. Okay, so I'll give you the answer in a few minutes, so stay tuned. Let's close that and launch the next poll, please. So the next slide, and Richard, you're back in the slide view, so you might want to change that again. There you go, thanks. So the next question is, what is currently the most commonly prescribed form of PrEP in the United States? So the options are generic TDF-FTC, branded TDF-FTC, known as Truvada, branded TAF-FTC, commonly known as Descovy, cabotegravir, also known as Apretude. So what is the most commonly prescribed form of PrEP in the United States currently? Give everyone a minute. Okay. Hopefully we could see the results. All right, so kind of split between generic TDF, FTC, branded TDF, FTC, and then folks think that TAF, FTC, and cabotegravir are less commonly used. So, this is really interesting. I'm going to tell you the results in just 2 minutes. So stay. I want to kind of keep a cliffhanger there. So next slide, please. So this is, oops, go back. Yeah, thank you. So this is a chart that was taken from an article just published this month in the Journal of the American Medical Association that uses pharmacy-based prescription data, trends from the beginning of PrEP availability in the United States in January 2013 through 2024. So, or actually 2023. So what you can see is that in 2013, the only option we had in that sort of dark blue or grayish line was branded TDF FTC, right? So you can see that it really, the uptakes increased, started to really increase and become significant in 2015, 2016. and basically continued to increase, which was great. And then in 2019, we had you can see the dot on the time horizon there that shows when the introduction of branded TAF FTC or Descovy became available. And so you can see that actually sort of quickly, there was a quick uptick in that. And then that gray line continued over. And then in 2020, generic TDF FTC became available. And so then that, again, quick uptake and surpassed half FTC there. What you see at the same time is that Truvada, right, that branded TDF FTC line actually decreased around the same time as these other options became available. And then that line that you see at the very top is just total PrEP use, right? So considering these 4 options or 3 and then 4th option, which is in the orange or yellow, in late 2021, the FDA approval of cabotegravir. And then you can see, unfortunately, that the uptake of that did not follow the trends of these other PrEP options, right? So we didn't see any sharp uptick. It really has been a very slow uptick in use, and it still remains quite low. Next slide. So just to summarize a couple more things from this article. So the answer is over 1 million people have been ever prescribed a PrEP prescription in the United States. So if you chose the second option, you were correct. 89% of those users are designated as male according to the pharmacy data, which is pretty binary and limited to what's reported through pharmacy records. And the annual number of PrEP users has increased over time. So, in the early years, there was as few as 10,000 people using it. And in 2023, it was over 500,000 people getting a prescription in that given year. So, and then I just included the chart again, just so you can see kind of what I'm going to reference here, which is basically the generic use of TDF FTC has increased, and that actually is the most common form. So that was that blue line, right? So that's the most common. So whoever said that, you got that correct. But it's actually closely followed by use of TAF FTC. So that was actually considered the 3rd most common in the poll that we did. So basically what has happened, or what the authors theorize, is that generic use of TDF FTC has increased, particularly among insured people. So, obviously if someone's insurance is covering it and there's a generic form available, then the insurance company would encourage people to use the generic form, since they're biologically equivalent versions and much less expensive. And so that's what's really driven a lot of the generic TDF FTC use. But then the TAF FTC use, what sort of contributed to that? What the authors theorize is that there are programs such as the 340B pharmacy rebate program, which provides financial rebates to community health centers and hospitals and healthcare facilities that serve underserved communities, that they actually get some financial incentive for using branded drugs. And so that is likely contributing to the continued relatively high use of TAF FTC. So very interesting. And then sadly, cabotegravir represents less than 3% of PrEP prescriptions in the United States. So still very much not, very, very low levels. And that's been something that we've talked about through multiple sessions of this series, just about the different barriers to uptake in this. Next slide. So just who's taking cabotegravir for PrEP? So from the same article, there's a little bit more detailed information. So there was about 13,000 individuals who took cabotegravir, and 86% were male, 39% age 25 to 34 years old. And then if you look by region, I found this interesting. So over 1/3 of the cabotegravir prescriptions were actually in the southern area of the United States, and only 1/4 in the western United States. And so I just found that interesting because, with PrEP use in general, the West Coast has been, a lot of the coastal cities have been sort of the early adopters, but here maybe folks are happy with what they're already taking and are not switching to cabotegravir. So it's kind of interesting to think about that. 38% of folks got the cabotegravir through public insurance, 47% through private insurance, and then 13% were supported through the patient assistance programs. Okay, next slide. So I'm just going to shift gears here a little bit and talk about Los Angeles County specific PrEP data. So this is from another pharmacy-based resource called AIDSview. I encourage any of you who've not seen that website to visit it. They have lots of great dashboards related to HIV prevention and care outcomes that can be broken down nationally by the state and by county level. And so this is their estimates for PrEP use in LA County. So you can see over the same time horizon how, our trend has followed what has happened nationally. And it's estimated that 27,000 persons in LA County are using PrEP in 2023, or they received a prescription that year. Next. So then here's broken down by demographics. So what they show here is, under male and female, those labels, they actually say what percentage of new infections those groups represent. So for example, by sex, they say, 87% of new cases are classified as male, but then the green bar is what the percentage of PrEP users is. So even though, for example, females are about 13% of new cases, they're only 5.6% are PrEP users. So you see this is a way of highlighting a gap there. Unfortunately, because this is using pharmacy-based data, they do not have good and complete race and ethnicity data. So that is a shortcoming of this dashboard. But moving on to age, you can see, the younger folks, 13 to 24, represent 16% of new cases in LA County, but only 8% are PrEP users. So next, Richard, I think there's some animation just to highlight. Those are two. Oh, sorry, can you go back? So those are just two groups that, we do see just, places where we need to increase uptake. But there's actually, amongst all groups, there is still a lot of room for improvement. Next. So to complement that data, we rely on other data sources to look at specific priority subpopulations, especially by race and ethnicity. And so this is data that we collect through something called the National HIV Behavioral Survey, I'll call NHBS. It's a standard survey administered by through CDC funds in several large jurisdictions in the country. And so in LA County, we've been doing this every year, and every 3 years, it's in a different specific subpopulation. So, there's a cycle focused on men who have sex with men, a cycle focused on people who inject drugs, people who are high-risk heterosexuals. And then since 2023, there's been a specific transgender focused cycle. So what you see here is what PrEP use in the last 12 months. So folks are asked as part of a behavioral survey whether they've taken PrEP in the last 12 months. And these are limited to people who've had a negative HIV result. So what you can see in LA County is that, and these are considered to be representative samples. So we can basically take the results of the survey and say that these reflect in broad strokes what's happening in our county. So 48% of the MSM, or men who have sex with men, that they interviewed reported any PrEP use in the last 12 months. You can see the numbers for Black and Latinx were slightly lower than that overall average. And for white MSM, it was 58%. Moving on to the transgender population, this is specifically interviewing transgender women. 38% reported some PrEP use in the last 12 months, but that was definitely lower for Black transgender women at 24% and higher amongst Latinx TGW at 45%. During the cycles, looking at people who inject drugs and in high-risk heterosexual networks, the PrEP use was essentially nil. There was very, very, very little use of it, despite the fact that these populations can benefit. The yellow bar you see at the top is really important. So as part of our Ending the HIV Epidemic initiative, nationally and locally, our goal is to get at least 50% of estimated persons with an indication for PrEP being prescribed PrEP. So you can see that aside from white MSM, there's no other group that's meeting that benchmark here in LA County. What I do want to say is, 50% is like where we want to go, but actually we'd love to exceed that for all the population so that everybody who really could benefit would be able to get a PrEP prescription. Next slide. So a lot of the data that I shared up till now was really just whether people received a prescription for PrEP, right? So, or they took some PrEP. But I think what is an important and sort of understudied area about assessing the impact of PrEP is whether folks continue on it or are persistent or retained in PrEP care. So, the idea of people being covered during periods of risk, not just starting it and then falling off, but actually, for some period of time taking it consistently. It's harder to study and measure this. That is really the challenge. But Kaiser being a kind of a closed healthcare system, they've been able to look at this, and some of the data from there show that a lot of their patients, about 75%, are still on PrEP at 1 year, like coming in for regular PrEP care. But I'm really concerned about other data that's out there that suggests that PrEP persistence is really not that good. There was an observational study of young Black men who have sex with men in the South, and over 70% of participants had at least one period where they discontinued PrEP in that first year. The median time to them discontinuing it was 5 months, and many folks had a final discontinuation at 7 months. And then pharmacy-based PrEP data suggests lower persistence as well. So looking at people with commercial insurance, about half of them remained on PrEP at 1 year. So we also have some, local experience, right? So many of you who are here have either worked with or engaged with PrEP centers of excellence. When we looked at that data, we also know that a lot of the clinics struggle to keep people coming back for PrEP. And then next, I'm going to just show you, I'll show some data. Can you go to the next slide? Show some data about this. So actually, one of the things, sorry, Richard, can you go back? It's so hard when you're not driving your own slides. I'm sorry. So, one of the things I wanted to mention was one of the things we're thinking is as a field, what can we do to make PrEP easier, right? So I think trying to reduce administrative and financial barriers is certainly part of that. And I think the state has done a really good job with advocating to make sure health plans are giving robust coverage, also trying to give people other options of places to get PrEP, including through teleprep and things like that. And then long-acting injectables, which has been the theme of this webinar series, I think we all have a lot of hope that long-acting injectables are a part of that answer. Next slide. So as part of that NHBS survey that I referenced earlier, we did ask some questions about long-acting PrEP. And so what you can see here is we asked people, how interested are you in taking long-acting PrEP? And so 54% reported being very or somewhat interested in that. So there is a fair amount of interest in it. Of note, there was 20% who said they were very uninterested. So I think we don't know if those were the same people who are already taking an oral form of PrEP, or if there were other reasons they were not interested in long-acting PrEP. Next slide. And then this is data from our local public health STD clinics. One of our staff was running the data on folks who are getting cabotegravir through our clinics. And so, we were basically tracking people to see what's happening to them. And you can see, this is people coming in for their first, second, third, all the way up through their 8th injection. And this really, just without even having to squint, you can see the attrition of people, or the loss to follow-up of folks after they come in for their first PrEP injectable injection, visit. There's still a fall off from the first to the second appointment. And by the 4th appointment, basically fewer than half of the individuals are actually coming in for that. So there's still a mismatch there with regard to this long-acting injectables really helping us close this persistence or retention gap. Next slide. And then this is another question that we were asking folks in the NHBS survey, asking them their preferences for different forms of long-acting PrEP modalities, including some that don't exist. So the current options are at the bottom, right? So there's daily oral PrEP, there's the injectable PrEP every 2 months, and then at the top, there's the option of an injectable PrEP every 6 months, and then a PrEP implant, which could be received 1 or 2 times per year. So basically the dark blue are the most preferred options. Then we sort out people were ranking them. And so you can see what was most, excuse me, sorry, something's hiding it for me. So 49% of folks reported that injectable PrEP every 6 months would be their most preferred option. The PrEP implant, you had 21% saying that's most preferred, but then you had 47% saying that's not preferred at all. So so there's a little kind of two camps on that version. Daily oral PrEP, 19% saying that's option, but 43% saying that's their least preferred. And then injectable PrEP, 10% saying that's preferred, but there's a lot more people kind of in the middle on that option. So again, this kind of just gives us a sense of where folks are at. There are obviously, it's important to have different options for different folks. And I think, the main message of this is the twice yearly injections were the most preferred. And so on that note, I actually want to hand it over to my colleague, Dr. Siri Chirmamila, to talk more about the twice yearly injectable PrEP and the science behind that. So with that, I will hand it over to Siri. Thank you.
Thank you, Dr. Kulkarni. Thank you, Richard. Okay, so hi everyone. Good morning. Thank you for your time. So I will be talking about long-acting injectables, specifically about lenacapavir, and then we'll transition to talking about our pharmacy PrEP programs. So just to level set for everyone, there are multiple kind of considerations within HIV prevention modalities. I will be focusing on the injectables. So for the injectables, LAI, there's cabotegravir, Apretude, more commonly known, and then lenacapavir. So as I mentioned, lenacapavir is the focus of this talk, but if anyone's interested to talk about Apretude, happy to do that as well. Next slide, please. Okay, another level setting slide. So I get a lot of questions from community about the differences between cabotegravir and the very exciting results from lenacapavir that's been released in the last couple of months. So when we think about HIV prevention and HIV medications, medications inherently, we want to make sure they stop like the replication of HIV. So on the right-hand side, you see a figure showing like the different, once HIV is like in our bodies, like how it gets into our cells. And we have different medications that target different parts of that cycle for HIV. And the difference between cabotegravir and lenacapavir on the right-hand side, you can see cabotegravir is an integrase strand transfer inhibitor, so INSTIs, if you've heard of that. That medication works in that pathway. Versus lenacapavir is a capsid inhibitor. So if you see at the top in that right-hand figure, the blue, it targets different areas of the HIV life cycle. And so that's very exciting from a treatment perspective as well as a prevention perspective that it's targeting multiple sites. In terms of the difference in injection type, cabotegravir is an intramuscular injection that's given into the gluteal muscle, and lenacapavir is given in the abdomen. So it's a subcutaneous injection. In terms of volumes, which are important when we think about giving injections, with cabotegravir, it's about 3 mLs, and lenacapavir is 1.5 mLs, so about the same. And then in terms of frequency, cabotegravir, when you get it, you get a first injection followed by a second one, and then it's every 2 months. So your client, once they get those first 2 initial doses, they'll be coming in every 2 months, versus with lenacapavir, they'll get an oral lead-in with 2 tablets on day 1 and 2 with the injection, and then an injection every 6 months after that. And we'll talk about efficacy, but both have been shown to be efficacious in populations. And so to the next slide, please. Okay, so lenacapavir, this is the long-acting injectable that's given every 6 months. The clinical trials for this for lenacapavir are called the PURPOSE trials. So you have PURPOSE 1 through 5 trials. I'm going to be sharing results from PURPOSE 1 and PURPOSE 2 trials. Many of you might have already heard portions of these talks, so I'm hoping to all encapsulate it into one. The PURPOSE 1 trial was primarily done in cisgender adolescent girls and young women in South Africa and Uganda. It was looking at comparing injectable lenacapavir to I'll use the brand name. So injectable lenacapavir to Descovy, and then also to Truvada, which was very exciting because we don't have a lot of data for Descovy in cisgender women. And then the PURPOSE 2 trial is one of our more like gender diverse, ethnicity, race diverse studies, which is also very exciting. It was done in cisgender men who have sex with men, transgender women, transgender men, and gender non-binary. This study was done in the US, South Africa, Peru, Brazil, Mexico, Argentina, and Thailand. So very much so a global population and effort. And I'll go ahead and talk through those trials. Next slide, please. Okay, so this is the Purpose 1 trial. So it's lenacapavir, LEN, if you see that, that's a short form, and then CGWs for cisgender women. The results of the study were published in the New England Journal of Medicine, and this is just a citation of that. Next slide, please. So just to level set and understand the trial design for the Purpose 1 trial. So in this trial, once again, it was young and adolescent cisgender women who did not take PrEP or had HIV testing in the last 3 months and had their sexual partners identified as male. And there are, once they found those women, they were screened to see if they were HIV positive or negative. Those that were HIV negative were in one of 3 kind of groups, and that's what's circled on the upper right-hand side. So in women that were HIV negative, they were either given lenacapavir, so the injection, or they were given Descovy, or they were given Truvada. There was not a group that did not receive anything. So it was comparisons between those groups. So at the bottom in the blue box, you see that the lenacapavir group was compared to the background incidence. These are women that when they first got into the study were tested for HIV and they were HIV positive, and they were compared to that group. So that's the background incidence. The second group was between the Descovy group and that same background incidence, so those HIV positive women, and then comparing Descovy and Truvada. Next slide, please. Okay. So overall, the demographics, one thing when we're doing trials, we want to make sure that all those 3 groups that I showed in the circle, they're all similar to each other for the most part, because you don't want to be comparing an intervention that's different between different groups. So overall, between the lenacapavir, Descovy, and Truvada groups, the baseline demographics and clinical characteristics were balanced across the groups. The median age was about 21, and the majority were of Black race. And they also tested for STIs. The most common STI was chlamydia. And in each of the groups, there was a little over, in the lenacapavir and Descovy groups, there were about 2,000. And then the Truvada group, it was a little over 1,000. Next slide, please. So this was if any conferences y'all went to recently, or if you've seen this was the most exciting slide to see with the results. So for HIV incidence, so once those clients were put into those groups and given whichever medication or injectable, we looked to see, over a 52-week period, did anyone get HIV? So the background incidence, that first bar, that shows like just the baseline. So people that were screened into the study that were HIV positive, if they were not on, that was like the comparison group. And then lenacapavir, it shows 0 and like 0 on top of it. So that means it's 0 infections, which was very exciting. And then the next one after that, the red bar, is Descovy. There were about 39 infections. And then for the Truvada group at the end, there were 16 infections. And so that was, once again, really exciting. Next slide, please. Okay. So as you noticed in the previous slide, there were HIV infections that were noted in the oral PrEP group, so the Truvada and Descovy group. So I'm sure a lot of people on this call are aware one of the common kind of concerns and issues we have with medications that has to be taken orally is adherence, the ability to take it every day. And the investigators in this study also looked at that. So let me orient you to this graphic a little bit. So adherence at the top. So oral PrEP is a pill that you take 1 pill every day. So high adherence was considered as 4 or more doses in a week. Medium was 2 to 3, and low was less than 2. So as you can see over time, so you want the dark blue is the high like adherence. You notice over time for Descovy and Truvada on the left-hand side, it starts to decrease over time, and that's not good because you're not completely protected for HIV in terms of prevention. And so this just further kind of solidified what, I see in clinic as well as like our community members talk about, that it is hard to take a daily pill every day. It's great that we have it, but we also need to think about like meet people where they're at if it is hard. And so just emphasizing again that the slide was oral PrEP adherence waned over time. Next slide, please. Okay, another common concern similarly to Apretude that we had was whenever you get an injection, you can have injection site reactions. This was also a common concern in the Purpose 1 trial as well. So when we talk about injection site reactions, what we're talking about is when you inject like either into like the buttock muscle or even in the abdomen as well, you create a drug depot there, which is like the bump where all the medication is, and that elutes over time. So that nodule does go down over time, but it can be very concerning for someone that's not aware of it, and it can also lead to discontinuation as well. So in the Purpose 1 trial, among the 25,000 injections, only 4 led to discontinuation, which is good to see. Nodules, pain, and swelling also over time, which is what the x-axis is showing, the different time points. It also shows that those went down over time, which was also good to see. Next slide, please. Okay, so that's just a very high level overview. I picked certain parts of the Purpose 1 trial to share. We'll go into the Purpose 2 trial results. Next slide, please. So as mentioned earlier, this trial design consisted of one of our most gender diverse populations, a global population, which is also very exciting. It was primarily done for cisgender and bisexual men who have sex with men, transgender women, transgender men, and gender non-binary. For those that were not on PrEP, no HIV testing in the past 3 months. One thing you'll note right here was that in the Purpose 1 trial with cisgender women, Descovy was included as one of the groups. In this trial, it was not, because Descovy had already been studied in a similar population. So beyond that, similar trial design. So there was one group that got lenacapavir every 6 months, and then one group that got Truvada. And they were compared to that background HIV incidence group. And next slide, please. So in terms of characteristics, as I mentioned earlier, you want to make sure that the groups that you're comparing are similar to each other in every other aspect. And at baseline, the demographics and clinical characteristics were balanced between these two groups. The age range is a lot bigger. So between 17 to 74, the median age was our adults, young adults, 28 and 29 years old. The majority were non-white, which is also exciting because more representation and diversity in clinical trials is needed. And I'm glad the Purpose 2 was able to do that. And yeah, and then the participants on the right-hand side, it's just a breakdown of the different countries they went from. Next slide, please. Okay, so another exciting result. So similarly, in the lenacapavir group, there were only 2 infections compared to the Truvada group, which had 9 infections. So this was also another very exciting a portion to see as well as part of the results when it was presented. Sorry, next slide, please. Okay. In terms of injection site reactions, this was similar as well to the Purpose 1 trials, that the most common one was the nodules and then the injection site reactions. So nodules, pain and erythema, but those over time did go away. And in this group, it was among the 15,000 or so lenacapavir placebo injections, 29 discontinued due to those injection site reactions. 26 of the 29, so the majority were in the lenacapavir group versus 3 in the Truvada group. Next slide, please. Okay, so that is a very big overview of the Purpose 1, Purpose 2 trials. Once again, very exciting. And I will move on to, we'll pivot a little bit, but definitely open to questions once the Q&A opens up. Okay, so our next part of this expanding PrEP in LA County is talking about community access points. I'm going to be talking about our pharmacies and our community pharmacies that we've been working with. So utilizing community pharmacies as community access points for sexual health prevention services. And this is one of our partners, Aviva, that we're working with that's prescribing PrEP. Next slide, please. So utilizing pharmacies as community access points. So I always like to think of, like, when we're thinking through programs, like really getting down to the client level. I think depending on the, department, whoever you're working for, sometimes this can get lost. So making sure whenever we think about programs, what is the client actually seeing when they're, walking home or walking to school or walking wherever, like what are they seeing in their community in terms of access for their health? And so traditionally, if a client wanted to access sexual health prevention services, they would go to medical providers, majority through outpatient clinics. Telehealth became more like a big player, obviously, during COVID, and more clients became aware of it as well. And so that's traditionally what it was. If you wanted sexual health prevention, you had to access a medical provider. The pharmacies, we had to start thinking through what are other community access points where we could give PrEP and PEP. So pharmacies, community-based organizations are other touch points that our client would access in their communities. And then utilizing those community access points as client touch points, they're able to hopefully get them into the medical provider as well. Next slide, please. Okay. So utilizing our pharmacies as community access point for HIV, PrEP, and PEP. So in 2019, SB 159 was passed that allowed pharmacists to initiate PrEP and PEP without a medical provider prescription. So for PrEP, it's up to 60 days, or PEP up to 30 days within 2 years. It mandated Medi-Cal to reimburse pharmacist services for PrEP and PEP, and it prohibited prior auths on medication access. Next slide, please. In addition to SB 159, recently this year, February 2024, SB 339 was passed. That was built on that initial legislation to allow pharmacists to provide PrEP beyond HIV PrEP beyond the 90 days if you collaborate with a medical provider. So this could be through a memorandum of understanding, standing orders, a collaborative practice agreement, and I'm showing like the legislation text on the slide there. Next slide, please. Okay, so these are our pharmacy PrEP PEP partners. We have 8 of them that we work with. They're independent pharmacies, and they're listed on the left-hand side with the associated service planning area for those pharmacies. The majority are independent pharmacies. We do have 3 co-located pharmacies. So these are pharmacies within medical organizations. And most of them are offering comprehensive PrEP PEP navigation. So what that means is we have 2 different types with this program. So our PrEP PEP starts, our clients access the pharmacy. They're given a rapid test. They're evaluated for their intake and assessment for PrEP and PEP, and then they're given PrEP or PEP, and then they're provided information on medical providers to link to care. In the comprehensive navigation framework, in addition to what I just mentioned, those pharmacies have navigators that give the information to the client in terms of a medical provider visit, as well as schedule that appointment. Next slide, please. Okay, so this project started in April, May, and a lot of our pharmacies, this was new for them. And so there was a pre-implementation phase that ended in August. So these are numbers coming from that time. So the total clients that have been seen so far across those 8 pharmacies are 195. The majority were accessing these pharmacies for HIV PrEP. Eight pharmacies are being utilized as HIV rapid test access points. So 193 tests were administered. And the linkage to care, the majority were linked to care via a navigator, so a medical appointment within 30 days for 114 of them. A new metric in line with what Dr. Kulkarni was discussing earlier about the difficulty with understanding retention and metric persistence in PrEP metrics. We are also evaluating retention in medical care. So how we're looking at this is once a pharmacy initiates the prescription and gets them into medical care, the pharmacist keeps in touch with the client to see if they're attending their appointments with their medical provider. Some have even gone out to, they want to collect it a year out. So we'll be really excited to share the results once we have them. Next slide, please. Okay, pre-implementation. So for a lot of these pharmacies, we wanted to make sure there was good buy-in or understand their buy-in prior to them implementing Pharm PrEP or PEP. So there was high acceptability, appropriateness, and feasibility for Pharm PrEP, and a lot of pharmacists believed that the Pharm PrEP would fit into their current workflow and that it would be effective at their location. Next slide, please. Okay, and then some highlights and challenges. I won't go through all of these, but some of the main highlights were that our pharmacies became approved PrEP AP sites. They're able to access clients that were lost to PrEP care. So a lot of our pharmacies work with providers that might have a list of clients that were lost to care. So they work through that list to see if they can reach out to anyone and bring them in through the pharmacy. One of our pharmacies offers 24/7 HIV PEP access. That's Eddie's. Their graphic is on the right-hand side. And we also, from our side as a county, provided simplified data tools. Any program that we do, whether you're a county or not, you want to make sure you can evaluate it and that data collection is not burdensome. So we really were very intentional about collecting data for this program that mirrors the workflow of the pharmacies. And a lot of our pharmacies are interested in STI testing and LAI implementation. Our team is currently working through that with one of our pharmacies, so that's very exciting. Some challenges, which we're hoping, this group can share information about our programs, is a lack of client awareness. Not a lot of people know about Pharm PrEP and PEP and that you can get it through a pharmacy first without accessing a medical provider. And also the cost to pharmacy and reimbursement as well. It's not, the medication cost is not fully reimbursed by payers, as well as staff time. Next slide, please. Okay, and that is it for me. And I'll pass it over to my colleague, Richard.
Yeah, cool. Hi, good morning, everybody. So I'm just gonna wrap up this presentation with our LA County resources, where we're adding how much, and even a little bit about how much it has evolved over the last couple of years. So currently we have the biggest sources of PrEP navigation and PrEP assistance in the county have always been through PrEP AP, which is supported by the state of California through their Department of Public Health. And then we support the navigators at the PrEP Centers of Excellence, which is, as you know, about 15 funded contracted partners. So these have been the two biggest sources of PrEP access since 2016, as early as 2016. I remember because that's when I started. And it was originally through DHSP, and then eventually CDPH stepped in with the PrEP AP program. But over the last few years, a lot of this has changed dramatically, especially after the pandemic. We had federal funding given to other federally qualified health centers to provide expansion of PrEP services and STI HIV testing. So this would be organizations like LA Christian Health Centers, Asian Pacific Healthcare Venture, Pomona Community Center, just off the top of my head. And then there's additionally, we additionally expanded our Department of Public Health sexual health clinics to provide teleprep programs. And originally, I don't know if you may know, or for those of us who work COEs, originally they used to only really do PrEP and for like 1 month and then transfer out their patients to centers of excellence. But now they're actually doing ongoing PrEP care, even through their own teleprep program, which has been amazing. And then we also have our funded PrEP centers, pharmacy PrEP and PEP centers of excellence. To get people started on PrEP without needing to see a medical provider first. And then there's also the private your private care, or I'm sorry, your private business prep providers like Mr. Q Care Plus, et cetera. So, based on all that, especially post-pandemic, we've had a lot of expansion in the way people can access PrEP in LA County. So, resources wise for navigators and for HIV prevention workforce, really, we had two big groups previously: the LA PrEP and PEP work group, which primarily consisted of program coordinators, and then there was the Los Angeles County PrEP and PEP educators and navigators, which was LACPEN. The groups are currently on hiatus. They were previously meetings. On a monthly basis, but after COVID, it became a little complicated with the in-person meetings, and then they've just been on hold for a while. We at DHSP have been having internal discussions to see what we can get them active, what we can do to get them active again. It is kind of important to get that community now. With PrEP programs having expanded as much as they have beyond just uh, organizations that are funded by LA County. We also have the federally funded organizations. We have our pharmacy partners. We have our sexual health clinics. So I think it would be important or beneficial for a lot of us, even on the public health side, to get these groups together again, especially with how PrEP is set to evolve again with lenacapavir slowly creeping up. So we would definitely like to just, be on the same page and see how we can all better support each other to, increase access to PrEP across our county. There is an existing listserv for navigators. It's currently still managed by Raul Quintero. So, hi, Raul, if you're in the chat. Please feel free to contact him. Had his email right there if you want to be added. And that's it. Yeah, that's it for this one. A quick update on the program, Gilead Patient Assistance Program. I'm sure most of you have heard, but if not, after December 31st, or the end of this year, Gilead is no longer covering Truvada for PrEP. That's pretty straightforward. Then, it has been a generic medication for the last couple of years at this point, and it's I don't want to say relatively cheap. I think it's about $30 a month for even with I think even without insurance. But for the most part, they are no longer footing the bill of the name brand. They will continue to cover the Descovy brand for anyone who is on taking Descovy. There is a caveat where they will cover Truvada if it's for people who cannot use Descovy, i.e. cisgender women, since they are not allowed FDA. It's not an FDA approved for the Descovy, so they'll continue to cover Descovy for them. Notifications were sent out throughout October about this, so please contact your Gilead reps if you have not heard anything. Additionally, there is a webinar on Friday, November 15th. I'll post a link to it in the chat once we're done with the presentation. I think it's going to be a very useful, a very important webinar to attend, just to hear the complete, because this is just a snapshot of what's going on. So I would love everyone to attend so they can know what's the full decision and how this will impact other programs. I've heard rumblings of advocacy efforts from San Francisco, hoping to get Gilead to change their mind, but ultimately we'll see what happens soon. A quick update about this. This actually happened last Monday. So the Biden administration proposed a new ruling to eliminate the cost sharing for injectable PrEP. This was, and the Biden-Harris administration announced a proposal expansion of a contraception coverage under the Affordable Care Act, which includes LAI PrEP. This proposes a new rule for eliminating the cost sharing for injectable PrEP, which could mean easier access to LAI PrEP for people who have third-party insurance through their employer or who have purchased it through an exchange plan. So we are keeping an eye on this, and we're monitoring and seeing. We're hoping this just means a lot easier access to the medication over the next couple of years, because I know that I've heard how complicated it can be through third-party insurances. So we're hoping this eases it a lot moving forward. Just a little, and then a little bit about our resources for medical providers and uh, patients as well. So we do have right here in this link, again, when these slides will be sent out, we have our PrEP and PEP action kit. This is a real how-to for medical providers who are just starting out for oral PrEP. Does not have, we wanted to keep it very, we wanted to keep this kit very centered around oral purposes, since it is the most universally accessible and reimbursable for medical providers. So this kit has a service delivery checklist for how to initiate oral PrEP and then follow up, as well as a service delivery checklist, a PrEP and PEP billing guide, which allows for proper reimbursement through medical insurances, how to take a sexual histories, best practices to discussing sexual health, STI screenings and treatment guidelines. And we currently are developing guidance for injectable PrEP for Apretude, and then afterwards lenacapavir for when that's available. What just happened? Okay, there we go. This is the full kit. All the links are available to for anyone. Again, this will be in the slides, but the full kit's available at the end. So we also have patient resources in the kit about know your PrEP brochure, difference between PEP and PrEP. It's a little wallet size document, how to get coverage for PrEP regardless of insurance status. So the therapist, and it also has some nice posters for initiating a conversation in a medical office. A little bit of community resources. So these are not available in the PrEP and PEP action kit, but they are available through other links at DHSP. We wanted to highlight these because these have other HIV prevention options. The first document is our PrEP options that fit your sex life. So this is messaging that helps patients make an informed decision about their sexual health with using oral PrEP. It highlights how to use the Truvada medication, generic or name brand, on either oral daily for maximum effectiveness, or how to take it using the 2-1-1 method, which that number is a little lower for efficacy, but still highly effective. And it's a 2-1-1 method, which consists of 2 pills, no later, 2 pills. It's about 4 pills within 72 hours, 2 pills 2 to 24 hours before sex, another pill after that first dose, and then another pill following that the 24 hours later. And then we have our HIV and STI preventions charts. So we created a beautiful little chart here, standard file size 8.5 by 11, that outlines some of the most common practices to prevent HIV and STIs, which include your PrEP, PEP, DoxyPEP, barriers and condoms, and lubricants, just everything to help somebody develop a well-rounded sexual health toolkit. And recently, we actually are we worked together with LA Commission on HIV's Black Caucus to create some social marketing programs that show how great it is to be on PrEP, how empowering it is, how to live magnificent, and how to stay thriving in the community. I don't know if you see any familiar faces in these campaigns. We work together with our local HIV prevention workforce, so you'll see a lot of familiar faces who are working at our PrEP centers of excellence, or you might recognize them as local influencers or local artists. A lot of these marketing campaigns were made using local sources, so it has been beautiful to see. And I actually really love this campaign because it's very outside of the box for the Department of Public Health. So it's very straightforward, very in your face, just, enjoy your effing life, and, get on PrEP, stay on PrEP. And yeah. And lastly, we also want to promote our Get Protected LA DoxyPEP page, because STI prevention is HIV prevention. And we want to make sure, so we are fully invested in DoxyPEP here at DHSP. We all think it's a great way to for some patients who are hesitant about PrEP to get started. So, if they're not open about it now, we think that starting on doxypep is a great way to, open the conversation about biomedical interventions and episodic interventions as well, since, doxypep and 211 PrEP are taken somewhat similarly and when as needed. So it opens up the conversation to just get started on PrEP eventually in the future. So definitely, always discuss, open the door for doxypep when discussing PrEP or vice versa. And I believe that might be it. Cool. All right. Thank you. Oh, and Omar? Yeah.
Yes, yes. Okay, thank you all. I want to first start by thanking our panelists for a wonderful presentation. And just to note that you may not have seen it, but you are getting a lot of positive reactions throughout the three of your presentations. A lot of hearts, a lot of hand clapping. So just saying that. We did get a few questions in the chat. Sonali, so this question came early on in your presentation when you were presenting data on current uptake in LA County. So you received a question in the chat from Timothy Young asking if you can share a little bit more on the data available for those individuals who are using PrEP while also using methamphetamine. So I'm not sure if you wanted to speak to that a little bit more.
Yeah, good question. So, just sort of a little bit more context. I mean, methamphetamine is certainly a contributor we know to HIV and syphilis infections in our county. We don't have what I would say is representative data, like just having the numbers of folks who specifically looking at people who use methamphetamine. But I can say that of our sample of people who inject drugs, like when we do that behavioral survey, the percentage of those folks who actually report methamphetamine use is close to like 70%. So that's really increased over time. So basically, extrapolating from that, I think we can say that when we sample that population, people who inject drugs, most of whom also use methamphetamine, that PrEP use is very low. But outside of that, there could be people who don't inject drugs who are using methamphetamine, and we're not capturing in other ways. I think in the future we do want to look at this more closely, but in general, that would certainly be something that, clinically, folks who are using meth, that would be one extra indication to really discuss biomedical prevention with them. But we don't have great data. So thanks for bringing it up. We'll think more about it too.
Yeah, of course. And folks, feel free as we're going along for the Q&A to post your questions in the chat. So we did get a few questions about lenacapavir. One question that we received from Matthew was, do you know if lenacapavir is being prescribed off-label at the moment for PrEP until CDC guidelines come out?
Siri, do you want to take that? Or
Yeah, to my knowledge, I don't think it's being prescribed off-label for PrEP. It is part of HIV treatment. So if you already are diagnosed with HIV, it's part of that treatment regimen, like for multi-drug resistant, right? It's almost like a last sort of effort with clients that are diagnosed with HIV that have resistance to other drugs. But to my knowledge, I don't think it is being prescribed as HIV prevention at this time.
I'll add that Gilead is planning. I mean, they've publicly shared that they're going to be putting the data forth to this FDA to get approval like by the end of this year. So I think it's hopefully right around the corner. And given sort of the findings being pretty dramatic, I think it will get approved. I think at this point, given that it's not FDA approved and it's going to be probably very expensive, that's a huge other topic maybe we can tackle in the future. But that I think that sort of limits the ability of providers to just do off-label use of it, and it's coming.
Yeah. We also have another question here in the chat related to the Purpose One study data presentation. So first, offering an affirmation for the presentation itself. But from David Hardy, we have a question. If you can comment on the modified ITT analysis plan, and which study participants were excluded from study analysis?
I'll attempt this one. So just to level set for like everyone, for like analyses with these studies. So when you're analyzing data, so I mentioned in the Purpose One trial, but you can apply it to any other trial. You'll have different groups, and different groups are compared against each other. So the thought is when you're doing this analysis, so in this case between lenacapavir, the Descovy, and the Truvada group, the clients that are initially in those trials, so in each of those buckets, we're using their data to analyze and get to the results that we did. So like the 0 infections in that case. So that approach to looking at the data like that, so whoever entered the trial once they were randomized into those 3 groups, we're using their data to make statements about how the intervention worked. That's called intention to treat. As you all are probably, as I described that the best way I could, you'll probably notice like not everyone's going to stay in the trial. You can't force someone to stay in the trial just because you want to see if an intervention works. So people will drop out of that trial, but we can still use that data to understand something about whether that intervention worked or not. So what Dr. Hardy was referencing, a modified intention to treat, means that when we have those initial buckets of groups, buckets of people that are in the different groups, over time, because it was a 52-week study, over time, some people will fall off for whatever reason. And I'll share some of those reasons with these trials from those different groups. But the data itself, in a modified intention, they will look at that data regardless. So they might look at it, or they might exclude those people that are lost to follow-up or for whatever reason left. So that's important to think about, because people could be lost to trial, like they could get into a group and then leave the study for whatever reason. And it's important because the people who are left in the study might tell us something about the intervention, but we also should think about the people who left the study. Why did they leave as well? So be very critical about what you're reading in these trials. I'm grateful for Dr. Hardy's questions, because that is something to think about. My understanding from when I read, so keeping that kind of level setting in mind, modified intention analysis is thinking through like that group, which group did they look at to get the data that they did? So that 0 infections with HIV, which data did they look at? So in the lenacapavir group, we had 2,134 that were 2,138 that received lenacapavir. 4 had infections at baseline. So that number goes down to 2,134 people that were in that group. So that group was utilized to make the data. Of those 221,34, 227 discontinued lenacapavir. Mostly 125 of those people withdrew. Some of them were lost to follow-up. Some of them became pregnant. So a little kind of caveat to Purpose One trial. This was a trial that included women that had reproductive age, so they could get pregnant, and if they chose to stay in the trial, they could continue to stay in the trial, which was unique to this trial, because usually when we pregnant persons are most of the time not included in trials. So but they were given the choice, so some of them left for that, and some for adverse events. And so similarly, they did that kind of analysis with all the other groups as well. So TDF, so Descovy and Truvada groups. I hope that answers the question. It's a very big explanation, but I hope that was the answer that needed.
Yeah, that was great. Thank you, Siri. Still on this topic of the lenacapavir results. So we have a question here from Robert Contreras. He says, so in the lenacapavir study, there were 2 infections among those individuals taking lenacapavir. Do we know why these 2 individuals seroconverted?
I'm not sure, Sarah, I don't know if you're aware. I'm happy. I mean, Dr. Hardy, if you want to speak, if you can come off mute and address any of these questions. I mean, being in the clinical research realm yourself, would be welcome to have other voices here where I know we have some local folks who've been involved even in Purpose too, but happy to hear from them directly.
So I think while we wait on a response to this specific question, there were some other general questions related to the presentation. Robert also asked earlier on, so there was a slide on injectable PrEP in Los Angeles County, noting that there was a decline from the first dose to subsequent doses. Do we have any information on what caused the decline? So I know, Sonali, you mentioned that one of the most difficult things is persistence, right? Regardless of the modality. So I'm wondering if you could speak a little to that.
Yeah, and I'll also address Terry Smith's question about discontinuing PrEP. So I mean, I think what I was painting is really like broad strokes, right? I mean, we obviously there's going to be people who make very well-informed decisions to stop taking PrEP, and kudos to them if they don't want it, don't need it. That's great, right? But I think that what we worry about, and I mean, I see this in my own practice in our SD clinic, is patients who are interested in it, start it, and then this is a prevention drug. It takes effort. You're not treating an infection or symptoms, right? So there's just a natural tendency that most of us have to stop taking things or following up on things that are more preventative. So I think that's really what we're concerned about is about that. And so, I mean, I think with regard to our clinic data, we're still digging into it. I think the factors are always multifactorial, right? So for some people, it could be the side effects, which with cabotegravir are generally pretty well tolerated. So I don't think that that's really that big a concern. But it can be insurance issues, which again, in our clinical setting, we're actually doing a really good job of navigating people through that. So I don't think that's contributing as much. The clinic model, like maybe folks don't like the way that we're kind of like piecing together our cab. You have to come in for labs and come into the injection. All of the timing of these things can be burdensome to people. And that's just a reality of like sort of the clinical situation we're all in about how to do the injectable PrEPs and get people's labs and everything done in a timely way. And then I think there's this sort of, again, like I was mentioning, normal attrition from doing something that is to prevent a disease or prevent an infection. So I think that these things are always multifactorial. And I think that I agree with Terry's comment. Actually, I think we need to understand more about what's really going on. I think to figure out what are the modifiable reasons, right? And so I think at least at a very basic level, we know that how do we reduce some of the administrative barriers? How do we reduce some of the or increase facilitators, right? So teleprep pharmacies are ways we can at least facilitate for some people how it's easier. I mean, going to a pharmacy is generally they can usually navigate your insurance issues, right? They have all that information right there and they can give it to you. The line's not that long. You're not waiting as long as you're waiting to see your doctor a lot of times. So I think that's what really we're trying to approach it from multiple angles because it's like a multifactorial problem. So thanks.
Thank you, Sally. So folks, we have a few more minutes left dedicated to the Q&A. Dr. Brooks, did you want to ask a question or add anything?
Dr. Hardy wanted to respond to the question, but he can't access his audio.
Oh, yeah, of course. Dami, Enrique, do we know if we can grant Dr. Hardy audio privileges so he can provide a verbal response to the group?
There he is.
Thank you.
Of course, of course.
Can you hear me okay?
Yes.
Yes, your audio is coming through clearly.
The small, but I think sort of important point, certainly for comparators and for expectations of what lenacapavir can do, is if you read the New England Journal paper very carefully, it's not very apparent. The PURPOSE studies actually did a screening protocol very different than all previous PrEP studies. They actually used HIV RNA screening both at this first screening test and then also at baseline on the day the participants all received their randomized medication. If either one of those HIV RNAs were in fact positive, indicating that the person was actually seroconverting, they were eliminated from the study, both before they entered the study and also after they entered the study and had received study medication. The reason I bring this up is that when you're comparing that 0 to other studies did not do this. They did not remove patients who had already been dosed. In fact, they didn't even screen them with HIV RNA because that test is very expensive. And so I think the important thing just to point out is that in reality, that was probably the right thing to do, is to take people out of the study who were seroconverting because they were already positive. But it's difficult to kind of understand how that might be operationalized, because persons are going to be seroconverting when they come in unless they're screened twice, meaning first time and then a second time. So it's just important, I think, to look at the practicality of reproducing the lenacapavir protocol of doing an HIV RNA screening test twice if you think you're going to get 0 new infections, because that's something that no other study protocol has done to date. That's my only point.
Thank you, Dr. Hardy, for voicing these opinions. I did just want to know if you can also comment. There was a question in here earlier about those 2 individuals who seroconverted while taking lenacapavir. If you can talk a little bit about maybe some of the factors that contributed to those seroconversions.
Well, I think the point is this: is that there were 7 individuals who had a positive HIV RNA test after they received a dose of the study medication. Of the 7, 4 were receiving lenacapavir or had received lenacapavir, 2 had received the TAF product, and 1 had received tenofovir. They were in fact seroconverting because in between the time they were first screened for the study and the time that they actually started the study, they manifest HIV infection or perhaps became infected themselves anew. So by the time they actually got the first dose of the medication, they were already in the process of seroconversion, of study of conversion. So if analyze this study like every other study had been analyzed in the past, you would have found that actually there were 4 patients who did seroconvert while receiving lenacapavir, 2 on TAF and 1 on tenofovir. But of course, that's something that was not seen in this study because they modified the intent to treat. They did not keep the patient on the randomized study group, even though they received a dose of the medication. They took them out so that they would not count against the randomized drug.
Thank you so much for providing that clarification. That was very helpful. All right, folks, so it looks like we have reached the end of our Q&A period, unless anybody else has burning questions.
There's one in the chat.
Oh, there is one here. So we recently just got a question here from Damone. So the window period is 6 months. Doesn't other HIV counselors or doctors explain this to the patient about possible contraction of HIV? So is that explained to patients?
So I can address that. So actually, the window period is considered more narrow now, as depending on what testing technology you use. So traditionally, back in the day, like when HIV tests weren't that sensitive, you could have a window period of 6 months where you had contracted HIV, but your results would not come back as positive yet, just because the tests weren't able to pick up earlier HIV. But the tests have gotten so much better, and any standard lab-based test, the window period really is around 2 weeks. So that's basically, the window period is definitely shorter. I mean, you could give people like 2 to 4 weeks, really, if you're using like a point of care test, depending on which one you're using. But I think what's the thing with this, you normally with oral PrEP, for example, we will test somebody, like we could do a rapid test and we'll send the lab off for the like more sensitive test and start them on oral PrEP, right? And then if we find out they actually have HIV, right, because of the more sensitive test that the lab is detecting, we can tell them, you know what, stop your PrEP, or actually usually you'll just add on, or you could tell them wait till we get that, right? Wait 5 days. But normally here you're going to do the injection the same day. And so then you can't really stop it, or you'd really want to add on other medication. And this medication is not really used for treatment right now. So that's why they were doing all these extra tests, was really trying to identify. And I think Dr. Hardy's point about like, how does this work in the real world clinically, I think is a really great one that we have to think more about. And hopefully, I'm sure we'll have some great experts like himself and other clinical educators who can help us think through this with workflows. So, thank you. And I do see one more question for Richard. Yeah.
Yeah, so this will be our last question, and then we'll have to go to the evaluation and closing remarks. Richard?
Hi. Yeah, so how does your DA slide DHS site obtain the kit that was mentioned? Very simply, I think you're actually relatively close to the DHSP building in Koreatown. So if you want, I mean, I'll drop off my contact information here in the chat, and maybe we can coordinate either me going there to drop them off, or you can come over to DHSP to pick them up. Either way, because I don't think we're too far from each other. I'm usually in office Tuesdays and Wednesdays to coordinate any pickups.
Thank you, Richard.
Great, thank you. So our next piece is to go to the evaluation and then come back for some closing remarks. As I mentioned, if you stay till the very end, we will be doing a drawing for 3 $50 gift cards and the evaluation. So we will take a few minutes to complete the evaluation, and then we will do closing remarks. So the evaluation link to completing the evaluation will be put in the chat. There you go. So if you could just take a few minutes to complete this, it's the only way that we have any kind of data on how effective or how important or how useful these kinds of workshops are for your service providers who are serving these populations. And Omar will be putting on some R&B music for you to complete the evaluation. All right, Omar, I think we're done. If you haven't completed the evaluation, you can continue to work on it. Once you submitted your evaluation, you should have been redirected to a website to enter into the next drawing for those that have completed the evaluation. And that will happen on Tuesday, November 5th, 2024.
Mhm.
So next slide, please. So I want to thank everyone for attending our final injectable PrEP community workshop. I particularly want to thank our panel presenters from DHSP. This has been one of the most well-attended workshops, and we appreciate all the work and effort you put into the presentation. Just as a couple closing remarks, so over the past 24 months, we have conducted, as part of this initiative, we have conducted 7 online community workshops to help disseminate information about injectable PrEP and other PrEP products to Black and Latino gay, bisexual, and other men who have sex with men, and Black and Latina transgender women, both to consumers and to their providers. We hope these workshops have been useful in helping you to assist clients from our priority populations in accessing PrEP here in LA County. So we've done 7 workshops. Here is a list of our 6 workshops that we've done in the past. So the first 2 workshops were really on the science of PrEP, and that was pill-based PrEP. The third workshop was on accessing LA PrEP here in LA County, and that included a variety of presenters and providers talking about where and how we can access PrEP here in LA County. The fourth workshop was on implementing LAI PrEP in particular with our priority populations of Black and Latino MSM and transgender women, and looked at the practical and cultural considerations of implementing injectable PrEP with these particular populations. And that included providers that were actually administering injectable PrEP to these populations. Workshop 5 was looking at some developed tools and tips for developing effective messaging around PrEP. And then our 6th workshop was on uplifting the voices of Black and Latino and Latina MSM and transgender women and their experiences with injectable PrEP. All these workshops are available on our CHIPTS website, and including this final version, which will be put up in the next couple weeks. So